Next speaker, Jonathan Golledge, he's a professor of vascular surgery from JCU. Jonathan is a preeminent staff specialist in vascular surgery at Townsville University Hospital and distinguished professor at the James Cook University. Jonathan is going to present us on his work on developments in peripheral vascular conditions.
Wow, what an amazing talk, David. Well done. So thanks to David Whitman and the Academy for the opportunity to talk. I'm discussing abdominal aortic aneurysm, which is a condition I see not infrequently as a vascular specialist. You can see a bulge of the inferior aorta here. And this patient was a very fortunate one because they came back about a year later for routine imaging, and the sonographer who took the ultrasound was concerned that the aneurysm might have leaked. And you can see indeed there has been a leak of blood here into the back of the abdomen, and this patient was asymptomatic at that point. Most are not, most suddenly die when that happens, and they underwent emergency surgery and are still here today. But overall, abdominal aortic aneurysm thought to be responsible for around 200,000 deaths per year worldwide. So currently, the only treatments available for aortic aneurysm are surgical repair. There are two main operations: endovascular repair, you can see illustrated here, where a stent graft is placed from the groin into the weakened aorta and secured at the neck of the aneurysm and distally. So the idea here is that blood passes through the stent graft, avoiding the weakened aneurysm sac. But unfortunately, in around 20% of patients, leaks occur between the stent graft and the wall of the aorta, and so the aneurysm sac remains pressurized. And in these cases, there can be late rupture of the aneurysm, and that's now well reported. The other operation is a large open surgical procedure where a laparotomy is performed, the aorta clamped above and below the weakened artery and replaced with a prosthetic tube, as you can see here. And this is quite a morbid operation, approximately 5% perioperative mortality and other significant complications. So because of these weaknesses of the current surgical repair, most aneurysms are currently treated conservatively. So when first diagnosed, if aneurysms are small and at low risk of rupture, then they're simply managed by expectant imaging. You can see an example of that here. A small aneurysm, 35 millimeters, is followed by repeat imaging for 7 years, but eventually most aneurysms continue to expand in diameter, and so the risk of rupture increases, and around 3/4 end up having surgical repair. So we were interested in the potential of developing drug therapies for aortic aneurysm when we started looking at this mouse model. The angiotensin II infusion mouse model involves infusing angiotensin II subcutaneously into hyperlipidemic mice. And some of these mice then develop a bulge, as you can see, of a suprarenal aortic aneurysm, which is usually a bleed into the aortic wall. But not all mice that receive angiotensin II develop aneurysm. You can see an example here where the mouse has been resistant to angiotensin II infusion and looks very similar to a saline control. So we carried out microarray studies and looked at genes that were upregulated in the aortas of mice that developed aneurysms. And to our surprise, one of these genes was a bone protein originally only thought to play a role in bone remodeling called osteoprotegrin. And we went on to study OPG in some detail. So firstly, we showed that it was also upregulated in human aneurysm. You can see immunohistochemistry and Western blotting confirming that. And we went on to study the effect of OPG on human vascular smooth muscle cells in vitro. And OPG firstly stimulated apoptosis of vascular smooth muscle cells and also the release of matrix degrading enzymes such as MMP9 and the upregulation of the angiotensin II receptor that you've already seen is implicated in aortic aneurysm. So we then went back to the angiotensin II model and asked the question whether knocking out OPG would affect the response to angiotensin II in terms of development of aortic aneurysm or aortic expansion. And indeed it did. So you can see in clear bars here, the OPG deficient animals were less responsive in terms of aortic expansion to angiotensin II infusion, and also were less likely to rupture their aorta compared to wild-type animals. This appeared to be due to downregulation of a range of matrix-degrading enzymes, MMP2, 9, and cathepsin in those examples. So our next question, understanding that most patients who develop aortic aneurysm are older and probably not suited to some more toxic medications, we were interested in the potential of repurposed drugs. So we started with an angiotensin II receptor blocker, irbesartan, and also studied PPAR gamma ligand stimulators, rosiglitazone and pioglitazone. And we asked the question whether these agents could reduce the expression of OPG in human aneurysm samples maintained in vitro. And you can see here that irbesartan incubation caused the reduction in OPG production from these human aneurysm samples, and similarly for the PPAR gamma ligands. So back in our angiotensin II model, we tested some of these agents as well, and pioglitazone in this in vivo model also downregulated OPG and reduced the expansion of the aorta. So this suggested to us that a repurposed drug that had both angiotensin II receptor blockade and PPAR gamma ligation ability could be a potential treatment for small aortic aneurysms. And we therefore became interested in telmisartan, well-known angiotensin II receptor blocker, but also has been reported to have PPAR gamma ligation ability. So we designed a randomized controlled trial, the TEDDY trial, to test whether 40 milligrams telmisartan daily for 2 years would slow growth of aortic aneurysm with a range of secondary outcomes measured from CT imaging. Our main outcome was from 6-monthly ultrasound measurement of aortic diameter. And overall, we randomized 210 patients from the US, Netherlands, and Australia between telmisartan and placebo, followed them for 2 years. So this is the main outcome for the trial, and unfortunately, telmisartan did not slow aneurysm growth. You can see in filled bars, the telmisartan group, no effect on aneurysm growth compared to the placebo group, no significant difference. So that was a bit disappointing, but we know that the risk factors for aneurysm growth are not the same as aneurysm rupture. So, for example, high blood pressure is an important risk factor for rupture of small aneurysms, but not associated with aneurysm growth. But our question was, how can we measure the risk of rupture more accurately? And obviously, small aneurysms don't tend to rupture very often. We only had one patient in that trial, and I've already pointed out that patient had emergency repair and was very lucky. But none of the other patients ruptured. So we began a collaboration with a Swedish engineer. We've heard a lot in the last talk about finite element analysis, and Christian had developed a way to apply finite element analysis to CT scans. So you can see an example of a CT scan here of a patient having finite element analysis applied to it and measuring a site of high peak wall stress shown here in red. So Christian's software can measure aortic peak wall stress and also another surrogate measure of rupture risk, peak wall rupture index, which considers both the peak wall stress and also the strength of the aortic tissue to rupture. So we applied this finite element analysis to our sub-study within the TEDdy trial. So of our patients, about 70% had high quality CT imaging, and you can see the results of this here. So in blue is the placebo group, pink the telmisartan group, and at baseline had very similar peak wall stress, but over time peak wall stress increases in the placebo group, but not in the telmisartan group. And the situation was very similar for peak wall rupture index, again, very similar between groups at baseline, but steadily increased in the placebo group, not the telmisartan group. So this secondary analysis suggested that telmisartan was able to inhibit the increase in peak wall stress and peak wall rupture index, these surrogate measures of rupture risk. So to conclude, using genomics, we identified some drug targets within aneurysm tissue. Unfortunately, telmisartan was not able to limit small aneurysm growth, but in our exploratory analysis, telmisartan did appear to reduce this surrogate measure of rupture risk, understanding this is a surrogate measure and a secondary analysis of a negative trial. So I'd like to finish by thanking all the people contributed to this work. Corey Moran did a lot of his PhD and postdoctoral studies on the preclinical work, and our team in Townsville and internationally who contributed to the randomized trial that I pointed out, without whom, of course, we could not do the work. So thanks for the attention.
Thanks, Jonathan. Any questions for Jonathan? Can you get the microphone there, please? And then one down to Michael. You to Michael first. Oh, that's okay. It's okay.
Thanks, John, for over here.
Hi, Brian.
Hi. Really nice to see all your data over those years all pulled together like that. Just a question with the TEDdy results and the effects on peak wall stress. Were you able to look further, I presume, in animal studies as to the molecular correlates of the effects of telmisartan? Is OPG involved? Are there other molecular markers that would explain the reduction?
Yeah, it's tricky. I didn't go into it, but mouse models of aneurysm are not perfect by any means, and we certainly don't have the imaging to look in the mouse model at things like peak wall stress. We think there's probably a number of components. Reducing blood pressure is certainly part of it, and probably angiotensin II has effect on tissue dynamics that you know a lot more about than me. So I think it's probably a composite, but we haven't really managed to unpick all those details yet.
Yeah, hi, here. So, you know, obviously there is a big change in the extracellular matrix, the mechanical properties. That's why you have locally this phenomenon, right? So, I mean, that leads also to, if you give a drug now systemically, why would the drug do something so locally? But my question relates more to the FEM model, right? Because when you talk about the peak wall stress, the question we always ask as engineers is, what are the material properties? So did your Swedish collaborators be able to study mechanical properties of tissues from aneurysm and correlate this to the CT data? And then, of course, when you talk about OBG and bone, right? I mean, calcification of blood vessels are quite well known, and we know this is based on, one is the biomechanical loading of the flow, right? But the other one is the systemic one of the blood and so on. So can you comment on both, please?
Yeah, I'll do my best. So Christian's studied aortic tissue in the lab quite extensively when he was developing those peak wall rupture index, for example. So he's done a lot of work on that. In terms of calcification, yeah, I totally agree. Calcification obviously plays a key role in hemodynamics. Interestingly, sort of fitting with the data we had from TEDdy trial, we've done some studies on calcification and don't find it correlated with aneurysm growth, but I think it more has a role, as you point out, in the biomechanics. And, you know, I think this is part of the problem. You know, typically small aneurysm trials have focused on aneurysm growth as the endpoint. And that's because obviously ethically we can't leave patients to rupture. So the majority of large aneurysms get repaired, and therefore rupture as an endpoint's not realistic. And that's why we really need models to simulate the risk of rupture, because that's really what we're trying to prevent with any small aneurysm treatment. So I think it's a complex area, and there's more work to do, and we're doing more work in that area.
Jonathan, thanks very much. And this may relate to a previous question, but other drugs that affect blood pressure, apart from telmisartan, would they have a similar effect in reducing the risk of rupture?
Yeah, it's a good question. And I don't think we know that currently, and that's part of the problem with the trials that I've mentioned. So there's been in total 13 trials of small aneurysms, all relatively small because the condition is not super common. And the only way to do these a large trial of small aneurysms is an international trial. We're currently running one, and it's challenging running investigator-led trials across countries, but we're making progress on that. So I think really we will only have the correct answer to drugs for small aneurysms with those sort of international collaborative trials.